Good afternoon, everyone. My name is Jenna Webb, and I'll be the moderator for this afternoon's call. We are in the radio room in the Legislative Building in Regina, and with me is Saskatchewan Health Authority CEO Scott Livingstone. We are also joined by several folks on the phone. Today's event is going to include a presentation, and then we'll have time for questions. So to kick us off, I will turn things over to Scott.
Thank you, Jenna. Good afternoon. Joining me on the line is Dr. Susan Shaw, the Chief Medical Officer for the Saskatchewan Health Authority, and Mr. Derek Miller, the Chief of our Emergency Operations Center, and Dr. Shahab, the Chief Medical Health Officer, is also on the line for questions after we're completed the presentation. I'd like to start by passing on my condolences to the family of the individual who passed away from COVID over the last 24 hours. Again, I hope that these deaths increase our resolve for all residents across the province to help fight this disease. I'd like to also start by urging the public to thank our healthcare workers. They are making sacrifices and helping provide care during extremely difficult times. So for members of the public watching or listening, I would encourage you to reach out to healthcare workers you know, either through email, text, or phone calls, and thank them for the work they do each and every day. We want them to know that we are grateful for their hard work, so please join me in expressing our collective gratitude. Today, the Saskatchewan Health Authority is moving forward with the next phase of our COVID surge plan. I'm going to pass it over to Derek Miller in a minute to go through this information, but I'd like to set some context first. You've already heard publicly that the pressures in our system are intense, and that is absolutely true. Teams are under intense pressure to manage surge in COVID demand while still providing everyday health services to residents of the province. To date, we've managed this pressure largely by maximizing our existing capacity. Our ability to do that is over. Case surges have been too high, and projected case growth in the next 2 weeks is even higher. We need to act now, and we have. With that, I'm going to pass it over to Derek to outline the next steps in our surge plan. Derek, go ahead.
Thank you, Scott. Our purpose, as always, the health system is to adapt and expand our services to meet COVID patient demand, as well as to continue delivering essential services to non-COVID patients throughout the duration of the pandemic. This afternoon, I'm going to touch on a few key areas. I'm going to review the recent forecasted case information. I'm going to talk about 2-week surge targets that have been established to build our capacity. I'm going to review the service slowdowns that are needed in order to help us achieve those surge targets, and then what exactly would be required in terms of a redeployment plan and our next steps. Recent and forecasted case growth, you can see the numbers on the slide. The graph depicts the active cases from the start of the pandemic through to what we've seen in the last month, and you can see by the red indicators the exponential growth in cases that we've been experiencing. Those cases directly have an impact on our offensive strategy in terms of contact tracing and testing, and then a certain portion of those cases end up as patients in our facilities, and we've seen drastic increases in the number of hospitalizations over the last month, 400% increase. Likewise, in our ICU capacity, currently we're using 31% of our ICU capacity is being used for COVID patients. This marks a major increase just over the last few weeks. With this context of the current volumes that we've been seeing over the last number of weeks, we have modeling information that allows us to look ahead and forecast, project out what that COVID demand might be in the future. In consideration of the potential lab-confirmed cases in a 2-week timeline, we could see over 500 lab-confirmed cases a day, and that's up from the 325 that we experienced on the 30th of November. And likewise, we'll continue to see our hospital census and our ICU census rise as well over the next 2 weeks, and we are planning for numbers up to 250 COVID-positive patients in our hospitals within that 2-week period, and in the ICU up to 64 potential COVID patients. So with this as our potential scenario, we are moving forward to immediately create a capacity and resources that will allow us to meet this demand. I'm going to look at this from the lens of both our offensive and our defensive strategy as we've broken out our approach to the response for the last number of months. So first off, on the offensive strategy, we've established a 2-week surge target to be able to meet the 562 average cases per day that we may experience at that point in time. In order to manage that level of demand in contact tracing, we need about 500 staff, be that licensed healthcare workers, unlicensed workers, and also data entry staff. In order to achieve an efficient approach to contact tracing, we have broken the process out into a number of steps and identified what type of staff and training is required in order to best perform each one of those steps. The public health nurses are a very scarce resource in the system during the pandemic, and we have really focused their efforts on the work that they are uniquely qualified and skilled to do in terms of case investigation and gathering contact names. We believe that with this skill task alignment process that we have enough public health nurses to be able to meet demand. That's not the case for all of the steps, though. In terms of case monitoring and contact monitoring, which happens daily after the person is identified and is in isolation, we are using mostly supplementary workforce individuals to perform that work with a combination of some SHA staff as well. We are working very quickly in order to increase the number of people that we have performing that work in order to free up our clinical staff to be able to focus on those things that they need to do. And that's where we're suffering the most. We have 2 tasks, the rapid case notification and initial notification of contacts that must be performed by licensed and certified staff. And we're falling short in terms of the number of people that are needed in order to meet this projected demand. And in order to meet that, the lever that we have available is to pursue service slowdowns, which we'll talk about shortly, in order to redeploy people and to perform these roles as part of the contact tracing effort. In terms of our defensive strategy, looking ahead 2 weeks, we have a targeted ICU number of 64 COVID patients requiring ICU within those 2 weeks. And just to put it in context for everyone, that's equivalent to about 28% more ICU bed capacity than currently exists right now in Saskatoon and Regina combined. So this is a major increase in patients requiring ICU care in our facilities. We will be surging to meet that by creating additional spaces in our hospitals where we're able to care for ventilated patients, and also surging in resources in terms of staff and physicians to be able to care for those numbers over the coming 2 weeks. On our acute care surge, we've identified a target of 250 COVID patients within this 2-week period. This represents, for just an easy reference, the capacity of the Cypress Regional Hospital in Swift Current and the Prince Albert Victoria Hospital combined. So it is a significant number of patients requiring hospitalization. And as we've said previously, in terms of our surge plan, we've identified spaces in our facilities where we can move into in order to create capacity. We've also are slowing down some services in order to help us achieve that. Likewise, we will be pursuing other ways of creating spaces where we can cohort COVID patients, and this may mean transferring patients to other locations where they can receive the right care in the right environment, and also support our approach to delivering care to COVID patients. We've referred previously to our demand curve and capacity steps, the graph you see in the bottom right-hand corner. Essentially, the demand curve representing COVID demand, and then our capacity that needs to increase a step ahead of that demand curve. We don't want to be in a position where we're riding the demand curve and where we're at risk of quickly becoming overwhelmed by COVID demand. So these surge targets will allow us to take those steps to get in front of the demand curve and ensure we're able to respond. In terms of the planning scenarios that we've been working on over the last number of months, this brings us to about 15% of the planned COVID ICU capacity that we projected at the peak, and about 19% of the planned COVID acute capacity that we have planned for at the peak. So we're not jumping to the top of our capacity by any stretch with these steps, although they do mark very significant movement in terms of our response. The other area where we need to surge resources is to create a pool of healthcare workers that would be able to respond to outbreaks that occur and are occurring across the province in long-term care facilities as well as our acute hospitals. With the prevalence of community transmission and also healthcare worker exposures, we see the devastation that cases amongst healthcare workers can cause on our services and cause major service disruptions. It can wipe out almost an entire small facility. It can take out significant portions of departments in our acute larger facilities, and we need to be ready to be able to respond to those so that we avoid critical service disruptions. So we've identified these resources that need to be established to support both acute and long-term care outbreaks as they may occur over the coming weeks. So how are we going to achieve these? As I've mentioned, we have worked over many months in order to increase our resources by staffing and bringing in external workers through the Public Service Commission or federal government workers to supplement our workforce, but it's not enough. We need to do more. We need to have specialized skills in some of these areas, and just the scope and breadth requires more significant action. We've taken a very targeted approach in terms of identifying services that can be slowed down in order to create capacity and resources for redeployment. And in this process, we asked our frontline clinical leaders and operational leaders to review each service line and assess it with a lens of what is the impact on patient care by reducing and slowing down that service, and also what are the resources that become available by doing that in terms of the number and also the skill set. And that allowed us to basically establish a way of identifying where we could achieve service slowdowns with the minimum possible impact on patient care, while also allowing us to achieve our targets for redeployment of staff. This is not a broad reduction of services like what was undertaken in the spring slowdown. This is rather a much more finely tuned adjustment in multiple areas that will allow us to achieve the capacity and resources that we need. The table on the slide outlines a number of program areas that are going to experience partial service slowdowns. The first one on the list, I'll note, primary health care consists of many services that are offered in community settings where we are going to see adjustments in the level of service provided, again, in order to achieve resources for redeployment. Also mentioned in terms of surgery, we are going to see a reduction in elective surgeries in the urban areas of Saskatoon and Regina. The north and rural sites will continue with their current surgical levels. And we've identified a number of other areas where we are again identifying resources to redeploy staff from. In some of these cases, it will be a very slight reduction, and it may not be noticeable immediately to patients seeking services. In others, there may be an impact where patients are no longer going to be able to receive the level of service that they may have been expecting to receive. I will say that these are very difficult decisions. The people that did this work to identify and prioritize where we can redeploy resources, it's very difficult to choose, as we know that every time you reduce a service, you have a direct impact on a patient and on the care that they need their everyday healthcare services, so they're definitely not taken lightly. There is a number of services that are listed that will continue as full services, and you can see them including mental health and a lot of our inpatient services. In addition to continuing with urgent, emergent, and cancer surgeries, some elective surgeries will continue. And then, of course, we will continue to operate all the various COVID services that have been established over the last many months. This table provides a summary of the number of resources by area and type of resources that have been identified for redeployment through this process. So you can see almost 600 full-time equivalent positions, individuals are going to be redeployed through this in order to surge into those areas of contact tracing, as well as to create capacity in our hospitals to be able to address this surge. This is in addition to other ways that we've supplemented our workforce over the past many months in order to meet the ongoing COVID demand, and ultimately the overall demand. It certainly exceeds the 588 FTEs that have been identified. And we are continuing to work with partners in order to supplement our workforce, be it Government of Saskatchewan, federal government, and other sources as well, to do work that can be done by their skill set. Over the longer term, we are going to continually assess on a weekly basis based on the modeling information that is available to us, as well as the current case trajectory, to assess our need for further slowdowns or to resuming services. In fact, we plan on taking a dimmer switch approach to services in the weeks ahead in order to scale up and scale down so that we can stay ahead of the COVID demand curve while also maintaining all of the non-COVID services that Saskatchewan residents need on a day-to-day basis. Changes in service delivery will vary by area of the province, just based on the local needs and how they need to be able to adapt to meet the COVID demand. So there will be some variation at different sites. Local communications will be used in order to advise stakeholders, the public, individual patients of the impacts and what those changes are. Concurrent to all this, we are working on a rapid and effective distribution and delivery of the COVID vaccine, working with the ministry as they lead this very important work over the coming weeks and months ahead. I'll finish by saying that throughout this significant change in services, the safety of our patients, residents, and healthcare workers is our number one priority. We need to protect all of these groups, despite the turbulent times that we're in. We are committed to maintaining non-COVID services as much as we can. As I said, none of these are easy decisions, and we know the impact that they have on people that are requiring the care. We are going to continue to keep any service disruptions as localized, targeted, and time-limited as possible, and we will be staging these in terms of a surge and accompanying slowdowns in order to meet demand, as we've described. Basically, we need to keep one step ahead of this virus. Ultimately, though, protecting the healthcare system is in the public's hands, and we need your help. I'll stop there and turn it back to Scott.
Thanks, Derek. So as I'm going to end by acknowledging that these decisions certainly temporarily reduce services to everyday health care for residents of the province. And as this is unfortunate, we also recognize how valued these services are by Saskatchewan residents and how important they are to their everyday health and well-being. But by not acting right now on behalf of the health system, we have the potential to be overwhelmed. And this would significantly risk our ability to care for the most urgent patients in both COVID and non-COVID settings. By working together, our teams have already ensured that these changes will not result in broad-based shutdown of the healthcare system. This is a service slowdown. We are committed to making these changes temporary, time-limited, and as targeted as possible. What we've done today is to dim the switch on these services, enabling us to redeploy staff to critical life-saving services. As Derek said, we will review every week whether that switch needs to be turned up or turned down based on our case growth, projected case growth, and the pressures on our hospitals and long-term care facilities. As Derek did, I want to remind the public that they hold the ultimate control of that dimmer switch. We will light up all of our services again when Saskatchewan residents help us make it safe to do so. I'll end with a quote from one of our intensive care nurses, Andrea Kozlowski. But before I read her quote, I'd like to note that this isn't just a quote from an intensive care nurse, but from someone who is a mother, wife, daughter, granddaughter, aunt, and niece. Andrea is like every member of the general public, except every day she heads into work to deal with more patients and more conversations with families of loved ones with COVID who may not make it. Here's the quote about how Andrea feels. We are watching and we are terrified of the storm that is coming. We're people just like you. We are tired, we are exhausted, we miss our families, and we desperately want normalcy back. But we need your help. Help us help Andrea and the thousands of patients, families, and healthcare workers across this province in the middle of this storm. Shrink your bubbles as small as possible, wash your hands regularly, don't go to work or out in public if you're ill, unless it's to seek medical attention. Abide by all public health restrictions, and please wear a mask when you're in public. We'll now turn it out for questions, and Jenna, go ahead.
Thanks, Scott. We'll move to questions and answers then. We have a few in the room with me, and there's also a few on the line. For those in the room, we did test the audio earlier, and the folks on the line can hear you, but you're going to need to project your voice, please, and thanks. First question will go on the line, please.
We have Lisa Schick with CJME.
Hi. I'm just wondering, do you know how long you're expecting these things to last? I'm thinking if somebody has a surgery in 3 weeks or even 3 months, what can they expect?
So depending upon what surgery it is, because it doesn't impact all surgeries across the province, patients will be contacted in the weeks out, particularly over the next couple of weeks, to reschedule because their procedures may be postponed. But as we've already pointed out, how this proceeds and how the dimmer switch is activated, whether there's more restrictions or less, will be determined based on the cases we see. So for those folks, that have already had procedures booked, in months to come, the changes that are in place right now affect those most immediate procedures over the next couple of weeks. But as we look at the caseloads, we may have to escalate, and that might mean more postponements, but we will know that and monitor on a weekly basis.
Is there a follow-up, Lisa?
Yes, I'm just wondering, why are you doing these slowdowns only now? I mean, we surpassed 2,000 active cases and 70 people in hospital 2 weeks ago.
So as I said in my beginning remarks, we have been using our existing resources to actually deal with what's in front of us, both in contact tracing, our offensive strategy and defensive strategy. And although, Derek highlighted on the resources that this will free up with respect to the slowdown to provide expanded capacity based on what we're seeing in the projections for cases, as well as the resources we've also onboarded from partners like the Public Service Commission and Stats Canada. I'd also remind folks that over the entire time frame of the pandemic, and particularly through the summer, we've also onboarded 627 other FTEs to support the COVID response. So we've been adding resources throughout. So it's not just this action now. We've been actioning on this over the last few months. You've seen our testing capacity expand. You've seen our contact tracing capacity expand, but we are pushing our teams to the limit, and we need to act now to not only strengthen their response, both on the offensive and defensive strategy, but to build a labor pool that gives us more flexibility to deal with outbreaks that we can't predict in long-term care facilities and hospitals where we're required to immediately replace staff, because the only other option is to reduce services immediately if we can't replace them.
Do I have any questions in the room?
Yeah. When we're looking at a forecasted lab confirmed cases in 14 days, 562, which is more than double what it was on Monday, what does that say about the current situation we're in when it comes to the spread of this virus?
So I think the main thing that it says is that with a widespread community-based transmission, I mean, we're dealing with a different kind of pandemic that we were early days, where we knew the travel cases and could identify them in those cases that were occurring in communal living. But there is widespread community-based transmission. And to talk about the forecast, remember, the longer the forecast goes out in days, the wider that confidence interval is around those numbers. So the lower the lowest confidence interval is, and the highest it is. So it's not a perfect science, but that's why we're planning. So why are we seeing these cases? It's because we're seeing large-scale community-based transmission, and we're starting to get into a period of, and you've heard this exponential growth, and that's what's driving the numbers.
How, and I understand it's not a perfect science, but like, how likely is it that we could hit that in 2 weeks? Like, is there a large margin of error, and there's a lot of room that if we change our actions today, you know, we're not going to get anywhere near 500, or is this like, you know, 95% sure we are going to see this in 2 weeks?
Well, there's so many different factors involved in how the cases grow and what we do, and including how people are abiding by existing public health orders. You heard Dr. Shahab yesterday, and I know he's on the line, but he talked about how we've seen yet another decrease in the number of contacts per active cases, which is good, but we also know that our test positivity rate is high in the province, and that's not a good thing. So how accurate are they? It's not a crystal ball, but with respect to us, you know, we have to plan. You know, we talked a lot about this in the early phases of the pandemic, you know, plan for the worst and hope for the best, but at the end of the day, we need to plan to something. We can't get caught off guard to the point where we're not having resources in place to deal with an influx of cases at that level. So with respect to how accurate it is, right now we know that the 14-day forecasts over the last few weeks have been quite accurate relative to what we're seeing. And we also know, as you know very well, it's not just those daily cases, it's what's happened over the 2 weeks beforehand that really is what we're worried about with respect to hospitalizations and ICUs imminently over the next couple of weeks.
Another question from the phones, please.
We have Phil Tank with the Star Phoenix.
Yeah, can you explain what form this deployment is going to take? Is this going to be people in existing facilities, you know, both on the ICU front and the other bed fronts, or are you looking at opening one of the field hospitals? Exactly where are these people going to be going?
Okay, good question. Derek, I'm going to turn that one over to you if that's okay.
Yeah, thanks, Scott. So the 500 plus resources, they are being mapped out to support different areas of the response. So in contact tracing, they would be, quite a bit of that work can be done remotely. Otherwise, they would be working together with the teams that are doing that in various locations across the province. For more the in-hospital type of surge, some of the staff would basically, if a unit is converted to a COVID unit, they would continue to work on that unit, but they would be redirected to support COVID staff. In some cases, we're creating new spaces in hospitals where we don't have current staff, and these resources that are being freed up and redeployed now, they would go to support those new additional beds where they didn't exist before. So they are being matched basically to based on their skill set and what training they have to where we can best employ them as part of the response.
Is there a follow-up?
Yeah, so sounds like you're not talking about opening up the field hospitals. My second question, maybe you could confirm that, but I'll ask my second question too. Apparently the SHA has reached out to physicians about retraining because we have an email here or a text message that's been sent. Can you explain a little bit about what's happening there and why?
Sure, and I'll just confirm that at this point in time, we are not in the process of opening the field hospitals, but we are preparing teams. With respect to the reach out that you referred to physicians for training, I'll turn that over to Susan, but just before I do, I'd just like to highlight that as part of the original pandemic response plan, in April of this year, we have been upskilling and training staff across this province for months to actually support COVID response and ensure that as we execute on the plans and as people start getting COVID across the province and showing up at health systems, our staff and physicians across the province are trained to be able to adjust their practice to deal with these cases. But I'll hand it over to Susan to give you some specifics of that request and what's happening.
Thank you, Scott. So yes, we've developed, I think, a very comprehensive training program for physicians that can either reconnect with skills that they had earlier in their training or actually develop new skills so that they can work alongside physicians, whether it be in intensive care units, emergency rooms, hospital wards, or if we got to that point in the response, into field hospitals. We're grateful for the partnership with the College of Medicine that helped us develop the content and the program. And this is a combination of online training where physicians can, from anywhere, comfort of their home, do some online modules to refresh themselves with the knowledge and the book skills, and then actually work alongside and train alongside physicians in Saskatchewan Health Authority facilities to refresh or gain new knowledge. This has been part of our plan. It's been extensively developed over the previous months, and we actually started the training in, I want to say, September of this year, and we keep communicating out to our physicians that this is a great option. If physicians want to be a part of, and many of our physicians already are, the physicians are looking for new ways to be a part of the response. We have a training program and are looking forward to continuing to train and expand our physician resource plan as the pandemic requires us to do so.
We've got a question in the room.
You mentioned preparing teams for field hospitals. What would those teams look like? Where would the staff be coming from to staff these field hospitals?
And so again, I'll turn it over to Derek in a second to give you more details about that, but I just want to highlight that as we've talked about field hospitals in the past and when they're activated and what we do, it's always based on that stepwise approach. So as we see the numbers rise, as we see hospitalizations or NICU admissions go up, we will use that same forecasted model to determine when we start escalating services and including the opening of field hospitals. And Derek, if I can turn it over to you around the plan, which isn't an integral component of this plan right now, but there is work on the ongoing basis with respect to the training and identifying the staff we would need for the field hospitals, but I'll turn it over to Derek.
Thanks, Scott. So I will say that over the last number of weeks, we have worked to reduce the amount of time we need to activate the field hospital as much as possible by making sure that all the equipment and oxygen systems and everything we need is set up, as well as identifying the various clinical processes and so on that need to be in place in order to actually activate it. So we're as close as we possibly can without actually pulling the trigger on activation. The local teams in Saskatoon and Regina have worked in order to identify what the skill sets would be for staff that would be deployed into the field hospital. I'll just keep in mind that the type of patient that would be admitted into the field hospital would be individuals who require care, but not necessarily at the level that would be received in an acute environment, so that they would be able to receive that safely in this kind of more austere care environment. So in terms of training and lining people up to be able to move into the field hospital, Scott mentioned where this is kind of at the end of the road for us in terms of our response plan. And by that point, we would have deployed hundreds of people across the system into all of the other steps going up to that. So by the time we actually head into the field hospital, we will be deploying staff from, I think, a multitude of different areas in order to make sure we can actually deliver that level of service that's needed in the field hospital.
Is there a follow-up?
There's obviously a lot of talk about the rising cases in Saskatoon and Regina, but we've also seen a lot of high case numbers in northern Indigenous communities. What's being done by the province and the SHA to address those rising case numbers and work to contain outbreaks there?
So specifically to the north?
Yeah.
So as you know, we have been working with both the federal government and First Nations leadership across the province since day one of the pandemic and talking to them on a daily basis with respect to what type of supports they would require. Sort of the best example, I would say, so far, besides some of the current ones that we're seeing, for example, in La Crosse, is the La Loche example, where it was truly a provincial response to support that community with the community leaders and the local chiefs connecting both directly with our healthcare services locally, but also their federal government counterparts and other provincial resources like the Saskatchewan Public Safety Association. And, those type of responses, particularly in those communities, require a different type of response because of some of the expectations and the difficulty in getting replacement staff. So that's where we come in to help support those efforts. But that's an ongoing dialogue, and as part of the pandemic response, we have had a liaison with First Nations and Métis communities since day one. So as they identify their needs through that group, we respond as best we can to help support them in their efforts.
Another question in the room?
What's being done to help testing, and specifically people that maybe don't have access to get to a drive-through through transportation? They may not have a car, they may use public transportation. I'm also thinking of places in rural, remote areas where we know it's some people may have to drive. We've heard a story about someone in Prince Albert getting in line very early on and being turned away, because I know that was very popular. Then they have to go to Saskatoon. So what are some of the things that are being done to make sure people can get tested when there are these challenges?
So good question, and specifically, to that issue around transportation through the winter months, and the weather is also a factor, as you know, and that's one of the reasons with the Saskatoon Regina facilities, we chose facilities that we could get people indoors as quickly as possible and warm. So we are continuing to expand testing, as you know, with the drive-throughs both in Saskatoon and Regina and PA. Particularly to Saskatoon and Regina, we're looking at how we extend hours, as well as put more staff in place, or even look at second locations for drive-through testing in both the centers because of the popularity. In the most extreme examples of the things that we've done to bring testing to people, in Lash and in other communities with communal living settings in the summer, we went door to door with the testing to try to get as many people tested as we could. There's surveillance programs we started in schools, and then most recently, one of the things that we're doing, and it's for long-term care, we've started a pilot with two of the new pieces of point-of-care equipment, the Abbott ID Now and Abbott PanBio equipment is in pilot right now in 8 long-term care facilities in the province over the next 2 weeks. And as we learn more about how to deliver those testing, both for surveillance of staff and residents, et cetera, in those facilities, to get on to identify cases early and address outbreaks early, we'll be expanding that province-wide with a more full surveillance and testing platform. The other thing that's going on in the testing space is, we are building both in the Regina and Saskatoon labs, our main labs, that capacity. We have been over 4,000 a number of times over the last month, but we are continuing to build. We haven't onboarded all of the resources that we've hired in lab. Some are still in training, but with I think the 15 or 16 or so has already significantly increased our capacity, and there's 20 more in that space. And then again, to reduce timing and also make it more convenient, the issue of the gene expert machines in 19 communities across the province, so that there's not people having to travel as far, because there's testing available in their own communities. And we are working with Gene Expert to continue to expand the access to cartridges so we can use that platform better. But we are using that as well to bring testing closer to home and make it more convenient for patients.
Follow-up, Adam?
Yeah, my next question is for Dr. Shaw. With these rising numbers and what's being projected over the next couple of weeks, can you just tell people what it's like to be working in the ICU, and what it's been like for your colleagues, and maybe some fears? I know Scott talked about that as well early on.
Thank you, Adam. I think that the biggest emotion is concern, and again, it's not concern that I'm going to get sick or my colleague is going to get sick. It's concern that we're going to be faced with more people than we can look after. And so that's what this planning is all about. How do we plan to have the right teams available to look after the patients that we're anticipating? Because as Scott said, even if we halt transmission completely, we still have all the cases and the people that were diagnosed over the last 7 to 10 days are just going to start to becoming ill enough to require hospital and then ICU admission. So really concerned, but there's also a sense of resolve. We're in this together. We work as a team. We have experience working under unusual circumstances, and are really pulling together to be able to make sure that we look out for one another while we're looking out for and taking care of our patients and their families. The other thing I just wanted to say that goes along with this is that I really miss the family presence at the bedside. And I know our patients do as well. We know patients really benefit from families being present in all of our facilities, and the fact that we can't do that right now because we need to decrease the foot traffic, we need to keep people safe, we need to focus on mission one, which is providing care. It's hard on staff, it's really hard on patients, and it's heartbreaking for our families. So that all adds up to being, it's actually quite a big burden. I think we heard it in Scott's reading of one of my colleagues, one of my nursing colleagues' words. They're heartfelt. It's a lot. And that's why it's just so important that people think about that. Please reach out and say thank you to those people in your community that are healthcare workers. And please also stay home and stay safe and keep your bubbles small, wear your masks. If you have symptoms at all, just stay isolated and connect virtually as much as you can to one another.
We've got time for one last question on the line, please.
We have Greg Wilson with Radio Canada.
Yes, hi. So you were saying that you're planning on slowly getting ready to get the field hospitals ready. What would be the moment that you decided the field hospitals were then necessary to put into use?
I'll hand it back to Derek.
Yeah, thanks, Scott. So there are each of the areas, Regina and Saskatoon, they have a detailed staged response to increasing demand in both of the centers. So at the end of the line, so to speak, is the field hospital, where we would be starting to admit patients into those facilities. So the key to making a decision on actually activating the field hospital would be, what are the projections looking like in terms of the modeling information, the current case trajectory, and when do we think that we're going to potentially need it, and then how long does it take us to activate it? And those are the kind of the key variables that we need to monitor and would ultimately trigger the activation of the field hospital.
Is there a follow-up?
Is there, in your modeling, is there a set number of new cases that you decide as like, okay, that's the moment where now it's getting to the point where we need these field hospitals?
So the modeling information, it would be based on the projected census in the hospital. That would be the number that we would be looking for. And it would also be based on what's the current situation in those facilities. Because non-COVID patients obviously we need to care for them as well. So there are a number of variables. So we don't have a number of, at this admission number, that equals hit the button on the field hospitals. There are more things to consider than just the number. Although the modeling, the current trend and trajectory of cases, those are key factors that we'll be considering.
That's all the time we've got this afternoon. Thank you.
Thank you.